Thank you very much. Thanks for giving me the opportunity to come and speak to you about the Canadian Longitudinal Study on Aging. And from now on, I will call it CLSA. So that's what CLSA stands for. Is this the one I'm supposed to use, John? I'm the lead principal investigator for the CLSA, and my two colleagues, Susan Kirkland from Dalhousie and Christina Wilson from McGill, are the co-PIs, along with multitudes of core investigators who do the day-to-day work of the study. And I just come and share the glory. And these are some of those people, and I'm sure you recognize some of these faces, and they represent researchers across the country. So just to talk about the CLSA itself, CLSA is designed as a platform. And what that means is that we are working with lots of researchers to collect these data. But as the designers and the collectors of this information, we don't have any special privilege to this data. This is designed as a resource for all researchers across Canada and globally. So people can apply to access these data to answer any research questions that they want to answer. And part of the goal is to generate evidence that informs decision-making in different parts of the country at a federal level, provincial level, or at the municipal level. And just to mention that the major part of the funding for this initiative for the operational side for collecting data and setting up the infrastructure comes from CIHR. And we also received substantial funding to develop the actual infrastructure to do the field work from CFI 5 years ago. So we have developed, I won't talk about that here today, but just to let you know that we have developed 11 data collection sites across Canada. We have a biobank, we have telephone interview facilities, we have genetic epigenetic labs, high throughput biomarker labs, and so on and so forth. Even though that is mostly used by the CLSA, it's also available to be used by other research teams if they want to do data collection on any specific projects. So what is CLSA? CLSA is a study of 50,000 men and women between the ages of 45 and 85 at baseline, and I'll talk about that in a bit, why we truncated at 85. And it is all based in the community-based sample, so we don't recruit at baseline people from the institutional setting. The 20,000 of the 50,000 people are randomly selected across the country from all the provinces. And these 20,000 only provide data through telephone interviews, questionnaires. And the remaining 30,000, what we call a comprehensive cohort, these are selected from 11 sites, 25 to 50 kilometer radius of 11 sites. That is Victoria, Vancouver, Calgary, Winnipeg, Hamilton, Ottawa, Montreal, Sherbrooke, Halifax, and St. John's, Newfoundland. And here we go to the homes of the people, and then we also set up an appointment for these people to come to a dedicated data collection site where they go through a fairly substantive data collection, and I'll show you more what we are collecting. And we also collect a healthcare card number from each and every participant from all 50,000, and we are going to be doing the data linkage with the administrative data, and some of the previous work that you heard from Anik actually could also be done with this particular data set, especially when you're linking the administrative data. And each and every of these individuals is going to be contacted every 3 years for the full data collection for the follow-up. So everything we collect at baseline, we repeat at the follow-up, including the biological samples. But in between each wave of the study, we also make a contact with each and every individual to make sure we haven't lost them to a follow-up, and we collect additional information from them. So just to give you a flavor, this is a busy slide. These poor people in the study go through a lot. We collect lots of information from them. So a lot of it is also collected through questionnaire, but this focuses mostly on physical assessments that we do. Obviously, height, weight, waist, hip measurements. We measure blood pressure. We do performance testing. We do vision testing, including retinal imaging, tonometry. We do hearing testing using a diometer, which is more of a screen. Lung function, we have DEXA measurements in all 30,000 people, including the body composition and hip and spine, as well as the vertebral fracture measurements, ECG, carotid ultrasounds, and we have a fairly in-depth assessment of cognitive measures on these individuals. And then we've also created 13 of different disease algorithms that basically takes data from self-report to their physical assessment data or their medication data to come up with a sort of a diagnosis of each one of the chronic conditions, including the disease symptoms, and those have been validated against the clinical charts of these subset of the population to see how well they perform. And we also collect some data from the 30,000 when we go to the homes of the people, the data on medication. We ask them to bring all their drugs, and we record their DIN numbers and the names and the dosage. But we will also do the linkage with the drug registries across the country as well. We also have a module on women's health because, surprisingly, there is very little data available in this country on women's health, so we had the opportunity to add that module here as well. Oral health is a major part of this study, and in addition to the administrative databases that are available through the provinces, we are also doing linkage with some of the other databases that are available across the country. For example, the Health Canada has air pollution data, so we have actually done linkage at the postal code for all 50,000 people for the air pollution data, and we are going to continue to add other databases to this platform. On the other side, we also collect fair bit of data on psychosocial aspects of the individual, social participation, social networks, caregiving, care receiving, mood, psychological distress. We actually ended up introducing a post-traumatic stress disorder measure because when we were designing it and we were doing some initial data collection, it became clear that in the CLSA we will have close to 5,000 veterans, which are defined and for which there is not a lot of data of this nature, so we decided to add some additional information. There's measures of coping and adaptation, injuries, work to retirement, retirement planning, social inequalities, mobility, which is sort of looking at people's mobility within their home and in their environment outside the home. Built environments, income, wealth, and assets, and the usual suspects related to lifestyle and socio-demographics, smoking, alcohol consumption, physical activity, and nutrition and nutritional risk screen too, and some of the other demographic variables. And we also collect 50 mils of blood from the 30,000 individuals. And the blood in the urine sample is aliquoted into 42 aliquots per person. And we basically have serum, plasma, whole blood, Buffy codes, PBMCs, and cells for creating cell lines in the future, and the urine sample, which is the random urine sample collection as well. And here are some of the examples of the biomarkers that we'll be doing on the baseline sample. On the fresh sample, we do the complete blood count on all the 30,000 participants. And we are doing some of these biomarkers, albumin, liver function, creatinine, high sensitivity CRP, ferritin, hemoglobin A1C, lipids panel, TSH, free T4, vitamin D, on all 30,000 baseline. And this will be repeated every 3 years. And we are also doing gene-wide genotyping, which is we are using a particular chip type and on 10,000 participants, and epigenetic marks on 5,000. And we just made an arrangement to do metabolomics on 3,000 of the 10,000 on whom we will do the genotyping. So it's a substantive database which is available to researchers to do all sorts of interesting things. And as other people apply for funding to do additional biomarkers that are not listed here, they get put back into the database so other researchers can use that. And here are some of the examples where some of the either grants have been applied or already funded that people are looking at biomarkers of mobility and muscle health. There's a project right now on hearing and cognition, falls, air pollution and chronic disease I mentioned, veterans health and PTSD. We are also trying to introduce a neuroimaging study as part of the CLSA, call it CLSA Brain. We have some collaborations with the European Union colleagues. We just recently got funded to do looking at the urbanization and mental health in older population. And this is a harmonization across several cohorts around Canada, US, and Europe. There are projects that people are looking at epigenetic clock and healthy aging, inflammation and cognitive aging, and metabolomics and prediabetes sub-study that I mentioned earlier on. And we are also trying to form collaborations, and that's, I guess, one of the reasons I'm here, is to start developing, first of all, introduce you to this wonderful resource that we are creating, but also to see what other types of collaborations we can form that benefits the CLSA platform as well as and supports the research activities or network activities of a network like TVN. Here is a CCNA, which is a Canadian Consortium on Neurodegeneration in Aging, and CLSA is closely working with them to see from two perspectives. One is to how they can use the infrastructure that we have, such as a biobank, which has the capacity to store 6 million aliquots, and also to see how CLSA platform can serve as a population control for many of their studies. And so there will be some discussions as to where we have common measures across different consortia. So just to give you where we are, the 20,000, which is what we sort of, we called it for ease of explaining it to people, tracking cohort. So this is basically focusing on answering questions that are relevant for policy making and other research enterprise. Our target was 20,000. We ended up collecting and recruiting 21,000. And the reason we went above the 20,000 because we wanted to make sure that we have enough people in the low socioeconomic group. So we went on oversample additional people. And the sampling frames were Statistics Canada, Provincial Health Registry, and where we couldn't do either of those, we use a random digit dialing as well. The baseline data collection for these 21,000 is completed, and actually we did the first release of data for researchers to be used in late fall, or I think middle of last year, 2014, and many applicants have applied to access these data. And as I mentioned, in between each of the main waves of the study, we do a maintaining contact, which happens at 18 months or so, where we collect additional half an hour worth of data. And there we have already completed contact with 19,000 people. And I think the most important part of this particular contact is that our retention rates are quite high still, and that's what we want to achieve as we start to follow these people, and looks like it's around 98%. And the first follow-up, these 21,000 people, is beginning at the end of this month. And the data are weighted to a sample weight, so we have created sample weight so you can actually use these data to come up with population estimates. I won't spend much time here, and we have worked with Statistics Canada to create some of these survey weights. The comprehensive data, which I think might be of more interest to the group here, as I mentioned, it is 30,000. We have also finished this data collection. We actually ended up doing a little over 30,000. And these data are being cleaned and prepared right now, and our goal is to release these data at the end of this year or early 2016. But we also started the maintaining contact with these individuals. Again, we have completed 21,000, and again, the retention rate is quite high. We are actually amazed that because we do a 1 hour and 20-minute interview in their homes, and then we bring them to this dedicated data collection site, and they spend almost 2.5 hours there, and people want to do more. And so we have to start educating our ethics boards to say, burden is not an issue for many people, especially in the community. They want to get involved in research more and more. And we have done some sub-studies, and we actually get almost 100% agreement to go on to do other measurements as well. And for this one, the comprehensive part, we have already started follow-up, and I think we have already recontacted a couple of thousand people in relation to this major measurement exercise of the follow-up. And as I said, this is developed as a platform. So the basically idea here is that we want to give these data to researchers in their offices to be analyzed. But releasing that data comes with a certain level of responsibility around the privacy and confidentiality of the individuals who are participating in the study. So what we are basically doing is to sort of set up special data sharing agreements with the researchers. They apply for our data. They build it around a particular question, and we release those data, and they are only allowed to use those data for that set of questions. And if they want to analyze different questions, they actually have to come back to us, and then the data are released for those purposes. So they can't just take the data and start distributing it to their friends. There are very specific agreements that we set up. And the process to access so far the alphanumeric data that we have includes there's administrative review, and then the approval, and we have a data and sample access committee, which is independent of the CLSA investigators who look at the application that comes from the research community. They evaluate, and they give a recommendation that the data should be shared, and we really haven't refused any of them except for one. And then the raw data, cleaned data, are provided to investigators, and any interesting derived variables that the researchers might have created, we ask them to share it back with the CLSA so we can put it back in the database so other researchers can use. There is some nominal cost for alphanumeric data. Right now, the questionnaire data we have is $1,000 basically it's a cost recovery. It's actually not a cost recovery also. It's way less than that. But we have a nominal fee of $1,000 for researchers. Graduate students get it for free, and postdoc fellows get one access to data free. And that's the model. And CIHR has this expectation that we will be charging for these resources. And for the comprehensive data, we'll probably have a tiered approach to the costing, from a questionnaire data to more complex data to the biological samples. And if you go to our website, you will find a data preview portal. And if you go under data set, we actually have listed all the variables that are available and what kind of frequencies and numbers you can see within that data, and all the applications and everything is available for you to use and fill out and access these data. These are some of the examples of the projects that have already been applied and have accessed the data. As I mentioned, falls and injury risk. This was a collaboration with Public Health Agency of Canada. There is a neurological conditions initiative that is out of Quebec. Veterans health, labor force participation, describing dementia in Nova Scotia, and so on and so forth. So this gives you just a flavor of some of the projects that people have applied data for now, even though the data are not fully ready to be used. As I mentioned, our renewal of funding, the renewal of funding has come through, and we have started the follow-up. And in the follow-up, there are a couple of things that we will have to think about. One is that as people move and get older, their cognitive impairment is going to be happening. So the issues of proxy measurements becomes a major issue. So we are developing some of the mechanisms to be able to do that. Another area is that basically some of the individuals who did come to the data collection site at the baseline would not be able to come. So we have a short battery physical assessments that we take it to the homes of the people. So basically the follow-ups are going to be much more complicated in relation to the accommodation strategy and to maintain the high retention rate. And that's probably one of the hardest things of this study going forward. How do we manage all of that within the resources we have? Some of the new modules that we have added in the first major follow-up is child maltreatment and adverse event, elder abuse, epilepsy, fair bit of enhancement on oral health and transportation modules. We are going to be adding the decedent and end-of-life modules. We are building it, and they should be ready to go in by the early next year, I think. As I mentioned earlier, that we truncated age at the baseline to 45 to 85, partly because of logistics, and secondly, we had designed this initiative. The questions that were designed, that drove the design of this study, were mostly interested in transitions and trajectories. So we are following people into the institutions as they move into institutions to understand what the transitions or trajectories are of institutionalization from community to institution. So we are in process of developing. Question here is, do we go out there and do primary data collection or start to link with some of the existing database? I see John Hurdy sitting back there, and we have been having some thinking through whether we should be linking to InterEye like data to capture some of the transitions into the institutional settings. We have a module on workability and also on subjective cognitive decline and meta-memory. And another area which was interest to lots of researchers out there was the sexual orientation and gender identity. So with that, I'll end my presentation. And these are our funders and partners that have supported the development and continue to support the development of the initiative. Thank you very much.